name is Tamara Lane. I am also a service manager with Milwaukee County's Community Access to Recovery Services branch, otherwise known as CARS. And I also assist Jen Alfredson in managing CCS, which stands for Comprehensive Community Services. And this is Module 2. We're going to be discussing the CCS positions and the roles and responsibilities that go along with that. So why don't we start off, let's just talk about the handouts that you guys have. You have my fabulous PowerPoint. And then this is actually, this packet of information right here, this is basically my slides all on one page for each position. So it's really a description of the role within CCS as well as what the responsibilities are for each position and the qualifications. And then we also have DHS 3610. You're going to hear me reference this a lot throughout the presentation. This is a list of the minimal qualifications that are required to perform a specific role within CCS. So Jen had mentioned in Module 1 the importance of being familiar with the policies and procedures for CCS. The other thing that you're going to see throughout our presentations is a lot of references to DHS 36. DHS 36 is the administrative code that governs CCS. It really gives you a overall view of what CCS looks like and all the different components that fall underneath the program. So in addition to really familiarizing yourself with the policies and procedures, read DHS 36. It is so important to know exactly what is required under the code. So for the purpose of this presentation, I didn't want to get up here and just rattle off, this is this position and this is this role and responsibility. What I decided to do is to create a visual. So this is Recovery, Inc. They are a new CCS provider in Milwaukee County. They don't really exist, but for the purposes of this presentation, I really want you to be able to put a visual to all the different positions that are within this particular program. This is the staff of Recovery, Inc. Not all of the staff members were available for this picture, as you'll see as we progress. So let me tell you a little bit about the onboarding process for CCS. So an agency comes to Milwaukee County and they say, hey, Milwaukee County, I want to be a CCS provider. And we say, great, here's what you need to do. 1, you need to have your agency complete a CCS application. The second thing they need to do is they need to develop a staff roster. And that basically is giving us a sense, what does your program look like? Who's providing what services? Who holds what positions? And it just really gives us a sense, hey, this is what we plan on doing. So within Recovery, Inc., we have a list of professionals that are going to serve within the CCS program. We have our service director, we have our mental health and substance abuse professional, we have a care coordinator, a prescriber, a therapist, a substance abuse counselor, a peer specialist, an employment specialist, and then we also have a psychosocial rehabilitation specialist. And next to their name are all the services they're going to provide. So while the roster that we have looks a little bit different, it's actually an Excel spreadsheet, and we have whoever at your agency that's completing it check off the actual services that are being provided. This is just for the sake of this presentation. So the roster does look a little bit different. Attached to each person on the roster are their credentials as well as their staff modifier. I do not have the modifiers listed here because I don't want to overwhelm you with that. Staff modifiers are an indication of what we bill under and what rate is assigned to each professional on the team. So this is Jackie Johnson. and she is our CCS Service Director. Jackie oversees the day-to-day operation of your CCS team. So she is really responsible for overseeing the quality, overseeing billing, documentation, doing regular reviews of all the work that is coming out of your program, and ensuring that it meets the standards that are outlined by DHS 36 in Milwaukee County. Now, Jackie should really, really know DHS 36. For Milwaukee County, Jen Alfredson is our CCS Service Director. Now, I don't know that Jackie's going to necessarily be able to recite DHS 36 like Jen Alfredson can, but Jackie really needs to be familiar with that code. So, in order to be a CCS Service Director, you have to be one of the professionals listed under DHS 3610, 1 through 8. If you want to look at that handout I gave you of DHS 3610, what I did is there's a line between 1 through 8 and 9 through 22. There's a reason for that. A lot of what you're going to see is either you fall under that 1 through 8 category or the 9 through 22 category. So that's why that's separated out. That's not always the case, but it's the case in a lot of circumstances. So, in addition to being the CCS Service Director, if you have someone who is very, very ambitious and can manage a lot of CCS work, your CCS Service Director could also be your mental health professional and or your substance abuse professional, depending on their qualifications. So the other thing that the CCS Service Director is responsible for, and what we've seen a lot of as we are getting into the CCS process and really building our teams, is we have a tendency to get a lot of calls from ancillary providers, care coordinators, asking us questions about DHS 36 and asking us questions about policies and procedures. And while we're always here for support at Milwaukee County, we really want your agency to have someone who is the CCS guru. Someone that anyone in your agency can go to and say, hey, I have this consumer that I think would be great for CCS. Or, hey, I have a question about CCS. So instead of calling myself or Jen Alfredson, then you really have the ability to have an internal staff member answering questions and being the go-to on that. And that's really what we're doing right now, is that we're referring consumers, we're referring staff members back to that CCS Service Director with any questions. Okay, so like I had said, Jackie is really responsible for supervising staff, making sure that clinical documentation, billing, or quality and appropriate. If in her reviews she notices that there's issues continually coming up, Jackie would be the one to develop internal trainings and really come up with ways to improve quality, improve service delivery. And then also what Jackie is responsible for is the maintenance of supervision and training logs. What we have to do at Milwaukee County is we have to demonstrate that our providers have the required trainings and are doing the ongoing supervision that they're required to do under DHS 36. Now, we've been asking your service directors to send us samples of this information so that we can track and make sure that this is being accomplished. But at your individual agency, when the state comes out to survey and take a look at your program and what you're doing, they're going to ask to see those supervision logs and those training logs. And it's the responsibility of the CCS Service Director to make sure that that's available. Then we've got Lori Rupert, who is our mental health professional. And the mental health professional is responsible for the review and the oversight of the work that is done by the care coordinators as well as the ancillary providers. So in this situation, the mental health professional is really going to be responsible for the paperwork, the assessment, the screening, authorizing services on the IRP. When a care coordinator gets a referral and they go out and they do their outreach process and they start the screening and they start the assessment, the mental health professional really needs to be a consultant. They review the case start to finish. They really familiarize themselves with the client so that they know when they look at an individualized recovery plan that they have to sign off on and authorize services, that those services being put in place are appropriate. So to be a mental health professional, you have to fall under 3610 1 through 8. You also have to complete the Wisconsin State Mental Health AOTA functional screen training, as well as being part of the CCS assessment training and the IRP development training. So under DHS 3615, a mental health professional completes the determination of needs statement. And when Jen gets into her flow, she'll talk about that a little bit further, exactly where that comes in the process. But the mental health professional is the only individual on the team that can complete that document. The mental health professional reviews the mental health AOTA functional screen, the assessment, and the IRP. They authorize the services on the IRP. They are a must-have. The mental health professional has to sign off on the IRP. Now, with saying that, they're not strictly a signature. I've seen a lot of documents come through that we've been reviewing for quality and appropriateness and just making sure that our care coordinators are really understanding the process. And there's a lot of little mistakes that come through on the IRPs. The mental health professional should be catching these things. They should be questioning the care coordinator before they sign off on the IRP authorizing the services. So the mental health professional serves as a clinical consultant for the CCS care coordinators and other ancillary staff. So let's say you have this case that you're really struggling with, not really sure what to do, where to go, what services to put in place to really help support someone. Your mental health professional is going to be your go-to. And hopefully they have been reviewing documentation, they've been involved in team meetings, they really have a working knowledge of a consumer so that they can really help support you in the process in moving this person further along the recovery path. So the other component that's really important but not required is that the mental health professional participate in recovery team meetings. Now, ideally, the mental health professional should participate in recovery team meetings because that's really how you get to know someone. That helps you understand really what they need, what makes them tick, who's their support system. It's not required, and I recognize that in some programs, your mental health professional may be someone totally separate. They may be a therapist in an outpatient clinic at your agency. So they may not have the time to dedicate to every recovery team meeting. However, with that being said, if a mental health professional cannot attend a recovery team meeting, there needs to be a clinical consultation, and it needs to be documented in the treatment record because the mental health professional ultimately is authorizing the services on the individualized recovery plan, the IRP, and if they don't have a working knowledge of what's going on, they can't really authorize the services. So if they can't be there, your case notes about that clinical consultation need to be really, really clear. I consulted with the mental health professional on this date. this is what we talked about. And then the mental health professional would have to do the same thing. And we're going to get into all of that with the clinical documentation training tomorrow, but I just want to give you a heads up that that's really, really important. So like I said, the mental health professional could also be an ancillary provider. They could be providing psychotherapy services. They could be providing substance abuse counseling. And there's different things that they could be doing in addition to being a mental health professional. It just kind of depends on how your agency wants to organize their time. So Lori is really, really ambitious. And not only is she our mental health professional, but she's also our substance abuse professional. Now, the CCS substance abuse professional needs to be involved in a case if there is a recent substance abuse diagnosis or a suspected substance abuse diagnosis. So let's say you're working with someone and you're kind of getting to know them in the process, and you go and you do a home visit. And Johnny doesn't have a substance abuse diagnosis, but you go in his house and you see beer cans lined up all on the counter. And you say, Johnny, what gives? And, he kind of hems and haws a little bit and says, well, maybe I have a beer or two now and again. It's at that point that you want to bring your substance abuse professional into the mix. You want to be consulting about the situation and making sure that whatever's going on with Johnny is at least getting a good clinical look, and there's some consulting being done. So the substance abuse professional needs to be an individual licensed under DHS 750284. This can be a physician knowledgeable in addiction treatment or a psychologist knowledgeable in addiction treatment. Also, you could be licensed under 750284, being a substance abuse counselor, which is a clinical substance abuse counselor, a substance abuse counselor, or a substance abuse counselor in training. So that's a lot of information. In addition to those specific qualifications, like the mental health professional, the substance abuse professional also needs to have training on the mental health aorta functional screen, the CCS assessment, and the development of the IRP. Because if that substance abuse diagnosis is present or suspected, then the substance abuse professional also has to authorize services on the IRP. So you're getting 2 signatures instead of just 1. So, the substance abuse professional's essential duties. They assess the consumer's substance use strengths and treatment needs, establish substance abuse diagnoses, reviews the consumer's mental health aorta functional screen assessment and IRP, just as the mental health professional would, serves also as a clinical consultant for the care coordinators and other ancillary staff, participates in recovery team meetings, but it's the same caveat with the mental health professional. It's not required. It's ideal, but it's not required. And there still needs to be that documentation if the substance abuse professional cannot be present at that recovery team meeting. And then, same thing. The substance abuse professional can also provide other ancillary services besides being the substance abuse professional. One very important CCS team component, every CCS team needs to have a mental health and a substance abuse professional. Because of the nature of CCS, an individual with a mental health condition and or a substance use disorder can be eligible for CCS. So it makes perfect sense that you would have both professionals on the treatment team. Like I said, the same person can serve in both roles. They just need to have the correct credentialing. This brings us to Alex Walker. Alex Walker is our care coordinator at Recovery, Inc. Throughout DHS 36, you are going to see service facilitator. Milwaukee County, we are calling service facilitators care coordinators. Only the CCS care coordinator can provide service facilitation services. The main goal of the CCS care coordinator is to develop, monitor, and oversee the services on the IRP and make sure that they are delivered in a manner that supports the consumer in attaining their highest functional level of independence. To meet the qualifications to be a care coordinator, you can fall under 1 through 22. So that's one of those exceptions where anyone that falls under 1 through 22 could potentially be a care coordinator. In Milwaukee County, we require you to have at least a bachelor's degree to be a care coordinator. Required additional trainings to be a care coordinator is the Wisconsin Mental Health AOTA Functional Screen Training, the CCS Assessment, and IRP development. So the essential duties of the care coordinator. And Jen will go through the flow very nicely in an upcoming module, but basically it is the care coordinator's responsibility. They get a referral from Milwaukee County. They go, they do the outreach efforts. They educate consumers about the CCS program, about the CCS process. Like Jen had referenced in the first module, someone can walk into your agency and say, hey, I want CCS. Tell me more about it. That is the care coordinator's responsibility, to sit that consumer down and really say, hey, this is CCS, this is the process, is this something that you're interested in? The administration of the mental health AOTA functional screen, that is something that the care coordinator does. They do that at initial, they do that annually, and that really tracks the consumer's eligibility for CCS. They also do the assessment of the consumer's needs. Same thing, initial, 6 months. The care coordinator assists the consumer in developing the individualized recovery team. With the recovery team and the consumer, the care coordinator helps develop the individualized recovery plan. And the care coordinator really is the facilitator of that recovery team. So they do all of the scheduling, they do all of the coordination, they run the team meeting, they make sure that it stays on track, it stays organized, and then as services are being provided, that care coordinator is regularly checking in with that consumer and saying, hey, how's this going for you? How's your progress with this? Do we need to add a service over here? Is this not working for you? Do we need to change something? So they're really, really the keepers of that individualized recovery plan. And they consistently check back with it. Is this working for us? So we'll get into the individualized recovery plan more, but the IRP is required to be entirely updated at least once every 6 months. It's a working document. It's going to change all the time, but you are going to want to make sure that it changes in its entirety at least once every 6 months. And that is the care coordinator's responsibility to make sure that that occurs. So as I indicated, the care coordinator oversees all of the services on the IRP and makes sure that they're being performed in a manner that's respectful and helpful to the consumer. And they're also responsible for putting in authorizations for services as the IRP progresses and changes. Now, The way that Milwaukee County is set up right now, as Jen had mentioned in the first module, we, as of late July 2015, we don't have a very robust ancillary network that we're working on. So many of our care coordinators are also providing some of those ancillary services on the array. So they're serving dual roles, overseeing the plan, but then also being a direct service provider. And under CCS, you can do that. So here we have Dr. Jackson Boyd. Dr. Boyd is our prescriber at Recovery, Inc. And Dr. Boyd is a really, really important piece of the team because prescribers generally have a knowledge that the majority of us don't. They really know the science behind medication, the science behind various disorders, and they know how various things can interact in the body, whether it be a physical condition or a mental health condition. It's really, really important to have a prescriber on board if they're willing to work within CCS, because they can help us gain knowledge that we wouldn't normally know. And in addition to that, they can diagnose, and they really can help the consumer understand their illness and exactly what the origin of that is and how medication can potentially be helpful for someone. Now, a little thing to note about CCS. Your prescriber does not need to be a CCS provider. So let's say someone has been established with a doctor at outreach for years. That's okay. They can continue to see that doctor, and that doctor can bill Title 19. The same thing goes for a medical physician. A medical physician can continue to be in the picture without being a CCS provider. So I just want to make that really clear, that an individual does not need to change prescribers to be in CCS. Now, it would be great if we could get prescribers into CCS, because it just makes sense to have them as part of the team, but then they're also responsible to do the training that's required as well. So to be a prescriber, you have to fall under 1 through 3 or 7 through 8. And besides diagnosing and prescribing, a prescriber can also provide non-prescriber medication management services. So providing education, helping support the consumer in taking their medications, increasing their understanding of the benefits of medication and the symptomology and side effects that go along with medications. Those are all things that the prescriber can do, as well as individuals that aren't exactly prescribers. So like care coordinators can also do non-prescriber med management services. So in addition to assessing, diagnosing, and treating mental health and substance use disorders, the prescriber also participates in recovery team meetings, ideally. They would collaborate with providers outside of CCS if they have a consent. So if there are medical conditions that may be impacting the consumer's overall health, and the prescriber is concerned about that, they would have the ability to obtain consent and coordinate services with that medical provider. Or if during the CCS program a consumer is hospitalized, then a prescriber may want to consult with the inpatient team, being the outside treating physician. So there's various roles or various duties that the prescriber can assume. So this is John Michaels. He is our Recovery Inc. psychotherapist. And the really important thing to note about psychotherapy is that it's a talk therapy rooted in research and established approaches. So you can't really just have someone who you go to and you just talk to and you talk about various things. There's really an approach that is rooted in research and has been established that a psychotherapist utilizes. So like DBT, dialectical behavioral therapy, cognitive behavioral therapy, solution-focused therapy. So those are all specific approaches that have been established over time. So a therapist is really going to use approaches that are rooted in research and established. Now, the goal of psychotherapy is to support the achievement of recovery goals, to help improve quality of life, to enhance one's satisfaction in personal relationships, and to improve overall function in work and performance in other areas of life. To provide psychotherapy, an individual has to fall under 1 to 10, 14, or 22. So providers must be appropriately certified, licensed, act within their scope of practice, and adhere to all the DHS relevant codes to their practice. So the essential duties of the psychotherapist is to diagnose, treat mental health, emotional or behavioral disorders, conditions or addictions. We discussed utilizing various therapeutic interventions that are established. The psychotherapist supports the consumer in understanding how their personal characteristics, unconscious processes, and psychosocial development impact them and the way that they interact with the world. So very Freudian. Taking a look at those unconscious processes and really what is rooted in a person that makes them do what they do. There's a science behind that. Supports both the team and the consumer in understanding mental health and substance abuse conditions and the impact on overall function. And then, of course, ideally participates in recovery team meetings. When we get to the point where we have ancillary providers, recovery team meetings don't necessarily need to be face-to-face. You can have particular members phone in if that works better. Ideally, it's what the consumer wants. If the consumer wants everyone to get together and that's just kind of their choice, then the team can do what they can try to do to accommodate that. But as Jen had said in Module 1, that's part of the negotiating process. We recognize that individuals on the ancillary, in the ancillary network may not necessarily have the time to be at every single recovery team meeting. So it's really just going to be finding out what works best for the consumer and best for your team. So this is really important. Licensed psychotherapists can only perform psychotherapy at a clinic that is a licensed outpatient therapy clinic. So that falls under DHS 35. You have to be licensed under DHS 35 to provide psychotherapy. So if Care Coordination Team X put on their roster, we're going to provide psychotherapy services, however, they're not licensed under DHS 35 to do so, they can't do that. So here we have Kevin Wilkie, and he is our substance abuse counselor. And a substance abuse counselor is also known as a rehabilitative counselor who counsels individuals in coping with substance use disorders. They are responsible for supporting individuals in learning the skills and mechanisms to cope with addiction and provide additional treatment for people with mental, emotional, or substance abuse problems. To qualify to be a substance abuse counselor, an individual needs to fall under 3610 2G 1 through 2. Needs to have a working knowledge of addiction with knowledge of psychopharmacology and addiction treatment, and providers must also be appropriately certified and licensed within their scope of practice. So providers could be a clinical substance abuse counselor, a substance abuse counselor, or a substance abuse counselor in training. You could also be a marriage and family therapist with licensing through the Professional Counseling and Social Worker Examining Board. So those are individuals that would qualify to be a substance abuse counselor. The essential duties of the substance abuse counselor: to interview the consumer, review records, and confer with other related professionals for further course of counseling treatment. So determining what issue is present and developing a course of treatment. The substance abuse counselor can also facilitate individual or group sessions to counsel consumers and support them in coping with addiction-related issues. A substance abuse counselor may also interact with someone's family and really help them to understand a substance abuse condition, as well as how they can navigate the recovery process and exactly what the recovery process may look like for someone. And as I indicated above, the substance abuse counselor establishes a course of substance abuse treatment. So let's see what else we didn't cover here. So just as the other professionals, collaborates with other treatment team members, plans and conducts programs to educate the client and help them overcome social difficulties, improve health, and prevent relapse. And then encourages consumers who are further along in the recovery process to share their experiences with others to offer encouragement and support. So just as the psychotherapist, there are rules around substance abuse counselors. Licensed substance abuse counselors can only provide substance abuse services in facilities that are licensed under DHS 75. Substance abuse counselors must maintain a separate medical record that is in compliance with the standards outlined under DHS 75 certification. So that's the same thing for psychotherapists. Regardless of if you're a CCS provider, there's still certain standards under your license, whether it be 75 or 35, that you have to maintain. So you still have to have your own treatment plan. You have to have your own progress notes, which can get a little confusing. With psychotherapy, and we'll get into this a little bit more when we talk about documentation, psychotherapy notes, individuals may reveal things in therapy that they don't want the rest of the treatment team knowing. So when we go to document for CCS, we document in a shared medical record. So everyone on the CCS team has access to those notes. So psychotherapy notes are special because there may be certain things that a consumer doesn't want you to know, maybe about their trauma history or various other things, maybe some abuse going on, that they really want to keep as part of their therapy appointments. So that needs to be kept in a separate medical record. Substance abuse, there's potential. It really depends on what the consumer wants, what they want revealed to the team. There may be certain requirements that need to be met under 75, but you definitely have to have your own treatment plan, your own assessment. So all that needs to be kept separate outside of the CCS medical record to maintain your own licensure. Here we have Danny Wright, and Danny Wright is a certified peer support specialist. Peer support specialists are an incredibly valuable component to CCS and the recovery team. Milwaukee County, we are really, really fortunate. As of today, I think we have over 100 certified peer support specialists in Milwaukee County, and that is the largest in the state of Wisconsin. So we really have a great pool of individuals to pull from to provide peer support services. The great thing about having a peer support specialist on your CCS team is they bring something to the team that no one else can. They bring lived experience to the team. And they really can give the consumer support and share their experiences in ways that a clinical provider may not be able to do. So the role of a peer support specialist, they really partner with the consumer in a mutually empowering relationship. And they work together to try to better understand mental health or substance abuse conditions, to really navigate the system, to learn how to advocate for themselves. So a peer support specialist can really, really do a lot of important things. In order to be a peer support specialist, you can fall anywhere, well actually there's a specific. You have to fall under 3610 2G20. And you have to be a Wisconsin state certified peer support specialist. So you have to go through the training, you have to pass the certification exam, and actually provide Milwaukee County with a copy of your peer support certificate. In addition to that, you must be 21 years of age as well, and have a minimum of a high school diploma or a GED. So as we had discussed, the essential duties of the peer support specialist are to really, really partner with that consumer in a mutually empowering relationship. The peer support specialist can support the family as well. If a family is really struggling with understanding where someone is coming from and what they're struggling with, a peer support specialist can help the family gain another perspective on whatever mental health condition or substance abuse disorder that particular individual is coping with. So in addition to peer support, the peer support specialist can provide a variety of services on the service array. You know, they can provide individual skill development and enhancement, wellness, recovery, and management, individual or family psychoeducation. There's really a lot of different things that the peer support specialist can do. Now, the peer support specialist participates in recovery team meetings, and they are a part of the team. Very, very important. So this is Devin Rogers, and Devin Rogers is our employment specialist. Now, employment specialists are relatively new to Milwaukee County. Last year we started a pilot with Milwaukee Mental Health Associates, and they piloted adding the component of IPS, Individualized Placement Support, into their community support program. Since that pilot started, we have expanded to offer Easter Seals and Goodwill for CCS. So right now we are piloting in 2 of our CCS care coordination teams, and the idea will be to ultimately expand to offer the employment component into the majority of our CCS care coordination teams. IPS is a really incredible model. It is highly, highly successful in helping consumers obtain and keep competitive employment. So I'm not talking about your sheltered workshops or your sheltered employment programs. We're really talking about getting consumers out there, getting them into jobs that they like and they want to do, and obtaining a competitive wage for that. So IPS, it takes a very, very special individual to go out and be an employment specialist, because you're not just part of a mental health treatment team, you really are the bridge to the community. Because once someone determines, hey, I want to work, that's all it takes. And there's some discussion and really describing what IPS is and making sure, like, hey, I don't want to just get some extra cash for Christmas, but I really want a job and I really want to work. This is really giving consumers an opportunity for people to meet them where they're at and get individuals working that haven't worked in a very, very long time. One of the consumers with one of the IPS programs, they used to pass medications to him underneath a blanket because he was so anxious and so sheltered. And the IPS team helped him secure employment in the community. And now he's going to work every day. He's happy, smiling, socializing. And we asked him, what do you love about working? And he said, everything. And he just lit up. And that really, when you think about it, how important is work to so many of us? And it's not our entire identity, but it gives us a sense of purpose. It gives us the opportunity to really support ourselves and to be a part of society and feel like you're contributing. So this is a really, really powerful role. And as it grows, you'll get to see the work that it does. But employment specialists are really your bulldozers of stigma. They go out, they meet employers. They educate them about mental health. They educate them about substance abuse. They really say, hey, just because someone has a mental health or a substance abuse condition doesn't mean that they can't work. It doesn't mean that they fall into all these different stereotypes that have been laid out for them. So that's why, from my perspective, and I've been involved with IPS since it started for Milwaukee County, it takes your salespeople. It takes your human resource specialists. It takes individuals that are really, really well-versed in what it takes to go out and develop jobs and connect people with what they need. So that's why with CCS, we went the route of building in Easter Seals and Goodwill, because they are, one, very well known in the community to do good employment-related work, and also they've done this. They've done this, they've been established, they understand it. So it's not like starting from the get-go. Because sometimes with treatment teams, you need to be able to come in and really flip the script. And when you're embedded in a treatment team, sometimes it's hard to step outside of that philosophy that you're so used to. Like, oh, well, this person can work when they're clean. When you haven't used for 6 months, then we'll sign you up for IPS. That's not how IPS works. Someone wants to work, doesn't matter. Doesn't matter if they're actively using, and you're still going to educate people about, well, you may struggle with getting a job because there may be a drug test. You're still realistic about it, but you're not there to dash people's hopes. You're there to really meet them where they're at. So that really is IPS. The other model that we're going to be bringing out of Milwaukee County is the clubhouse model, and that is done through Grand Avenue Club. So that's going to be another option for consumers as well. So now your employment specialist can be anyone 1 to 22. Extra additional training requirements. If you're going to run an evidence-based model, you have to have training to do it. So individuals that fall under this category to provide services either need to have training in IPS or they need to have documented training in the clubhouse model. So I gave you a pretty in-depth overview of employment, just because I'm so passionate about it, and I really think it's going to change the way that we do business in Milwaukee County. And, a lot of people may not necessarily know what it's all about. So here's my opportunity to get on my soapbox. So your employment specialist really is the focus. They focus on employment. That's what they do. They aren't doing medication management. They may be doing some symptom management as it applies to work, but they're not doing care coordination. Their focus is employment. And on a sidebar, in addition to employment, they can also support with education. So if someone is interested in getting their GED, then that employment specialist can also assist in supporting an individual to access the resources they need to do that. Now, with having Goodwill and Easter seals built into the treatment teams, they're not housed within the agencies that they work with. But they are required to be part of the recovery team and to have input on the individualized recovery plan. They refer and they collaborate with DVR. If a consumer wants to be involved with DVR, that's an excellent resource for them. And that employment specialist really serves as that bridge between DVR. Because I don't know about you, but I have walked through the DVR process with many a consumer, and it can be really, really challenging to navigate. So with having an employment specialist, that employment specialist really walks beside the consumer and helps them navigate that system. So as I had mentioned, the employment specialist goes out in the community and they do job development. So someone says, hey, I want to work at a pet store. So that employment specialist goes out and they go and talk to various pet stores in the community and try to really build a relationship to try to see if there's some employment opportunities within that particular store. And then, like I had indicated, this also includes education. So it's really about skill developing. Okay, and then we have James Monroe, who is our psychosocial rehabilitative specialist. And your psychosocial rehabilitative specialist can really provide a lot of services on the service array. When I think about this particular role, I think about like your group home workers. I think about your mental health techs. I think about your occupational therapy assistants. Individuals that really, really do a lot of incredible work, and they do a ton of work to support the consumer and the CCS team. So when you think about that, there's a lot of different services that go into that. Individual skill development, enhancement, wellness recovery and management, individual and family psychoeducation. So we're going to get into all of that and what that all means. So I know I'm throwing a lot of service names at you, but we'll get into that. Minimal requirements for a psychosocial rehabilitative specialist: you have to be 18 years old and have at least 30 hours of training in various recovery concepts. And I'm not going to read those all off to you guys because you have them. Basically, the psychosocial rehabilitative specialist works under the supervision of the mental health professional and the substance abuse professional. So they're the ones authorizing the services. So if there are supportive services identified on the IRP as being something that this particular individual can provide, then they are working in conjunction with that substance abuse professional, mental health professional, as well as the care coordinator and the rest of the recovery team to really, really help support that consumer. They participate in recovery team meetings if participation is approved and consented by the consumer. And then they also engage in ongoing communication with the recovery team as long as it's consented by the consumer. And that really goes for any member of the recovery team. Okay, so let's talk about methods of supervision. And this all falls under 3611. So clinical collaboration is a method of supervision that can only be performed by individuals that fall under 1 through 8. So meeting with someone, let's say a psychiatrist is consulting with a psychologist on a case, and they're going back and forth, and they're talking about what's the best approaches, and they're really, really trying to gather information, work together, and develop a plan. So that would be a form of clinical collaboration. Other supervision methods include individual. So a supervisor working one-on-one with a staff member to really consult on cases, provide whatever supervision is necessary to improve documentation, enhance service delivery. Side by side. So with the mental health aorta functional screen, what we have been recommending for new care coordinators is that they actually go out and partner with someone at their agency. And when we first started, we actually had our staff here go out, and we would have new staff shadow someone who's well versed in the mental health aorta functional screen. So this would be an example of side-by-side supervision. You're going out with someone, you're having them perform the work, you're seeing how they're doing, you're giving feedback on how they can improve their performance. Group meetings. When I was doing a training, I was doing a specific therapeutic intervention training. And a requirement of it was to meet as a group once a month and just kind of bounce off different experiences we were having, and then to work together to really develop interventions and ways that we could have performed better. So that would be an example of group supervision. And then any other professionally recognized form of supervision would also be okay. So for staff qualified under DHS 3610, the 1 through 8, these staff are required to have at least 1 hour of documented clinical supervision or clinical collaboration per month, or for every 120 clock hours of face-to-face psychosocial rehabilitation or service facilitation they provide. Now this is important, and I found this kind of interesting. So if you are a provider providing supervision and you fall under this 1 through 8 category, you cannot provide more than 60 hours per week of combined supervision, clinical collaboration, face-to-face psychosocial rehabilitative services, and or clinical services in a combination of clinical settings. So really, you have to keep track of your time. And that's pretty amazing. 60 hours a week is a very, very dedicated, wonderful professional. But that's a lot of work. So you're providing supervision and you're providing direct service delivery. So individuals that fall under this category that are providing clinical supervision really need to be careful about how much supervision, how much service delivery they're providing. Granted, that's a lot, but it's still something to be mindful of. So let's say your clinical supervisor has been working with a particular care coordinator for months, and they determine things just aren't improving. The service director has the ability to say, I think that you really need more supervision than what's required. So the service director can make that call. If they feel a staff member just needs a little extra support, they can go ahead and make that happen. So now for staff members who are qualified under 3610, 9 through 22, there needs to be at least 1 hour per week of documented clinical supervision. This also includes day-to-day supervision. So you have to have at least one time per week documented. But we've all done clinical work. Things come up day to day. There may be some random struggles, some situations that may be challenging. That supervision is available to you to use. And I definitely encourage you to use it because that's really, really important. And the great thing about supervision and consultation is that you can bill for it. So your supervisor and your care coordinator can both write a case note, talked about so-and-so, this is what we determined, this is the best course of action, and you can both bill for it. So documented. Your supervision needs to be documented in a supervision log. Remember earlier I talked about when the state comes in to do their review. I think they're coming in August to do our first one. And depending on whatever certification, whatever length of time we're given, they could be back in 2 years. They could be back in 3 years. Milwaukee County, we may very well and probably will do random audits and say, show us your supervision log, show us your training records. So you really want to make sure that this is present at your agency. So reference DHS 3611. Take a look at that because it will tell you exactly what needs to be in a supervision log. So in Module 1, Jen had talked about the training requirements, and I'm sure you are all well aware of the training requirements, hence why you're here today. So individuals that have experience working with mental health and or substance abuse conditions need the 20 hours of documented training, 90 days pre and 90 days post your start date with CCS. Individuals that don't have that experience, they're required to have 40 hours. Now, once you have obtained your required training to even start CCS, then there's ongoing training requirements. So, to be in CCS, you need to have at least 8 hours of in-service training per year documented. So however your agency wants to set that up. If there's a log, you keep brochures, you need to have some proof that you're actually doing the training that's required of you. So in-service trainings can include the time set aside for the in-service training. That includes discussion and presentation of current principles and methods for delivering psychosocial rehabilitative services. So I'm sure the majority of you have been a part of some sort of treatment team in your career, and maybe you had a drug rep come in, give an in-service. Someone gave an in-service about this assessment or this particular approach. All that counts. You just need to document it and be able to demonstrate this is what we did and this is how it qualifies. Presentations by community resource staff or other agencies, including consumer-operated organizations. So let's say NAMI does an in-service on, supporting individuals in recovery. That would count. And then conferences and workshops. And I think we all know what those are. So same thing with supervision, training needs to be logged. And when the state comes, when Milwaukee County comes, we're going to want to see those things. So really make sure that you're providing that information to your supervisor when you are doing trainings. So the question was, and Zach, correct me if I'm wrong, how does the agency decide how to pay their staff? The great thing about CCS is that it's a cost-based reimbursement. So agencies, if they want to, can pay their staff a little bit more than the typical Medicaid rate because the rate is substantially higher. It's meant to cover your staffing costs. It's meant to cover your overhead so that it doesn't cost anything for the agency to administer. So really it's up to the agency. But no, all billing for CCS comes through Milwaukee County. So when you enter your billing into CMHC, which will soon to be Avatar, that billing goes into a system, Milwaukee County cuts you a check, and then Milwaukee County bills Medicaid. And then we keep the revenue. So you're getting paid from Milwaukee County. And that's how that works.